Today we are going to talk about Janus kinase inhibitors or JAK inhibitors. First of all, what are the Janus kinases? Janus kinases are protein tyrosine kinases that are bind to transmembrane type 1 and type 2 cytokine receptors and mediate cellular response to numerous cytokines and growth factors. These mediators are important in immune defense and in immune mediated diseases. Janus kinase isoforms. There are four isoforms of Janus kinases: JAK1, JAK2, JAK3, and tyrosine kinase 2, which mediate signaling in pairs specifically associated with particular cytokine and growth factor receptors. So, how Janus kinase signaling pathway work? First of all, there are two types of receptors: type 1 cytokine receptors and type 2 cytokine receptors. In type 1 cytokine receptors, when interleukins attach with the receptors, which are transmembrane receptors, attachment of the receptor causes phosphorylation of Janus kinases JAK1, JAK3, JAK2, and tyrosine kinase 2, which causes JAK-STAT phosphorylation, and this pathway cause lymphocyte proliferation and homeostasis, and different T cell differentiation causes inflammation, erythropoiesis, myelopoiesis, and platelet production. And in type 2 cytokine receptor activation, innate antiviral defense mechanism activates. These all pathways cause intranuclear transcription and translation and formation of the target proteins. Examples of the JAK inhibitors are Tofacitinib, Baricitinib, Upadacitinib, Filgotinib, Psoriasis, and Abrocitinib, and there are many more. Selectivity of Janus kinase inhibitors for specific Janus kinases. For example, Tofacitinib and Baricitinib and Psoriasis are considered pan-JAK inhibitors, while Upadacitinib is considered highly selective for JAK1 inhibitor, but it also has JAK2 and tyrosine kinase 2 inhibitor action, while Filgotinib is highly selective for JAK1 inhibitor. Now, what are the indications of JAK inhibitors? It is used in Alopecia areata, vitiligo, atopic dermatitis, psoriasis and psoriatic arthritis, psoriatic juvenile idiopathic arthritis, rheumatoid arthritis, ulcerative colitis, and axial spondyloarthritis. Now, first of all, use of JAK inhibitors in vitiligo. In vitiligo, there is elevated levels of interferon gamma and cytokines like CXCL9 and CXCL10. How JAK inhibitors work in vitiligo? First of all, we can understand how vitiligo disease, the pathogenesis of the vitiligo is. It is via JAK1 and JAK2 enzyme. When activation of the JAK1 and JAK2 enzyme, interferon gamma activates transcription of CXCL9 and 10, which causes recruitment of cytotoxic T lymphocytes, and these T lymphocytes cause destruction of the melanocytes and the vitiligo. JAK inhibitors used in vitiligo are oral Tofacitinib, which is as we already know that it is pan JAK inhibitor, and act on JAK1 and JAK3. Dose is 5 mg per day for face and hands for 5 to 6 months. There is no major adverse events and results in complete repigmentation. Relapses on stopping of treatment can be there. And if 5 mg twice daily is used for 6 months, then mild side effects occur and slight improvement. Repigmentation rates were higher with concomitant use of narrowband UVB. Next is topical Tofacitinib 2% cream using twice daily. Concomitant use of narrowband UVB 3 times per week for 2 to 4 months yield better results. Only side effect is acne. Oral ruxolitinib is JAK1 and 2 inhibitor, is used 20 mg twice daily for 20 weeks. Next is topical ruxolitinib. Ruxolitinib cream 1.5% twice daily on light exposed areas with optional narrowband UVB. Response maintained after discontinuation of therapy at 6 months. Next disease is atopic dermatitis. Atopic dermatitis, JAK-STAT pathway plays key role in dysregulation in the pathogenesis of atopic dermatitis by overexpression of helper T2 cells, releases pro-inflammatory cytokines, and which activates the eosinophils and suppression of the regulatory T cells and maturation of B cells. Secretion of IgE, which binds to cutaneous mastocytes and releases histamines. JAK inhibitors in atopic dermatitis used are oral Tofacitinib 5 mg twice daily with no major adverse events. Then is topical Tofacitinib 2% cream every 12 hours for 4 weeks. Next is oral Baricitinib 2 to 4 mg used with or without topical triamcinolone 0.1%. This is FDA approved drug. And improvement of pruritus within the first week is noticed with marked clinical improvement at 16 week compared to the placebo group. Common side effects are nasopharyngitis, headache, increased creatinine phosphokinase. Next drug is oral Padacitinib. It is the selective JAK1 inhibitor and its dose is 15 to 30 mg daily. It is FDA approved in 2022. Marked clinical improvement at week 16. Common side effects are acne, nasopharyngitis, upper respiratory tract infection and headache. Next is oral Abrocitinib, which is selective JAK1 and its dose is 100 to 200 mg daily, approved by FDA in 2022 January. Reduction in pruritus as early as day 2 of the study is noted. Side effects include GI side effects, nasopharyngitis, infection with herpes, eczema, herpeticum and thrombocytopenia. Next drug is oral Gusacitinib, and this is JAK and SYK pathway inhibitor. 40 to 80 mg daily. Pruritus decrease in almost all patients at week 4. Next drug is topical Ruxolitinib and topical Dalgocitinib, which is non-selective JAK inhibitor. Next very important indication of JAK inhibitors is psoriasis. Psoriasis has several cytokines including interferon alpha, interferon, gamma, interleukin 2, 6 and 12, 13, 20, 23 transmit their signal after binding to the corresponding receptors via JAK-STAT pathway. Overregulation of JAK signaling with increased expression of the STAT1 and STAT3 in lineal psoriasis skin is noted. So, JAK inhibitors used in psoriasis are oral Tofacitinib, which is JAK1 and JAK3 inhibitor approved by FDA for treatment of adults, treatment with psoriasis and psoriatic arthritis at dose of 5 mg twice daily. Adverse events include herpes zoster, nasopharyngitis, infections, upper respiratory tract infections, UTIs, diarrhea, and mild cytopenia. In October 2015, FDA refused to approve it for moderate to severe psoriasis, alleging more studies were necessary on long-term safety. Next is topical Tofacitinib ointment 2% every 12 hours is used with favorable safety profile. Oral Baricitinib, it is JAK1 and 2 inhibitor, 8 to 10 mg once daily with nasopharyngitis side effects and infections. Oral Aprocitinib is a selective JAK1 and oral Solcitinib is also selective JAK1 inhibitor. Other JAK inhibitors in psoriasis are Itacitinib, JAK1 inhibitor, and Psoriatic is pan-JAK inhibitor. Next are Tyrosine kinase 2 inhibitors. The Tyrosine kinase 2 inhibitor drug is Deucravacitinib is an oral and selective inhibitor of tyrosine kinase 2, a kinase that mediates signaling of the cytokines involved in pathogenesis of psoriasis such as interleukin 23. In 2022, the FDA approved Deucravacitinib for treatment of moderate to severe plaque psoriasis in adults who are candidates for systemic therapy or phototherapy. Standard dosing for Deucravacitinib is 6 mg taken once daily. Next is Brepocitinib, a potent tyrosine kinase inhibitor and JAK1 inhibitor. Topical formulations are being tested. Other applications in dermatology, like used in dermatomyositis, Tofacitinib and Ruxolitinib, cutaneous graft versus host disease, and hidradenitis suppurativa, and lichen planus, cutaneous lupus erythematosus, and chronic hand eczema, pyoderma gangrenosum, cutaneous sarcoidosis, and granuloma annulare. These are the FDA-approved JAK inhibitors in different skin conditions. Like in psoriatic arthritis, the FDA-approved drugs are Tofacitinib, Upadacitinib, Baricitinib, and Deucravacitinib. In atopic dermatitis, Upadacitinib and Abrocitinib, while in vitiligo, topical Ruxolitinib. What are the pre-treatment, screening, and precautions use of JAK inhibitors? We have to take a careful medical history if patient has diverticulitis, GI tract perforation, history of thrombosis, current or past history of smoking, cardiovascular risk factors, and any known malignancy. And lab testing, we have to do complete blood count with differentials, white count, and platelet count, liver function tests, lipid panel including total cholesterol, LDL, HDL, and triglyceride, and screening for latent tuberculosis, hepatitis B, and hepatitis C virus. JAK inhibitors in pregnancy and lactation. These are contraindicated during pregnancy, effective contraception during and at least 1 week after the treatment is needed. Animal studies showed teratogenicity, including VSD and skeletal and cranial malformations. No FDA category assigned as yet. Both Tofacitinib and Vaccination excreted in breast milk in animal studies shouldn't be used during lactation too. JAK inhibitors used in pediatrics. Very limited data is available to establish the efficacy and safety in children. Topical formulations for mild disease such as alopecia areata or atopic dermatitis can be used as useful adjunct therapy. What are the restrictions for the use of JAK inhibitors? If patient is using concurrent treatment with other DMARDs, JAK inhibitors should not be given in combination with biologic disease-modifying anti-rheumatic drugs or potent immunosuppressants such as azathioprine or cyclosporine. And if patient is having age 65 or greater, and patient is having pregnancy or breastfeeding, having cardiovascular risk factors like myocardial ischemia or infarction, stroke, and history of thromboembolism, any malignancy, thromboembolic events, GI disease, if patient has diverticulitis or risk of perforation, lymphopenia, neutropenia, anemia, and infection. Pre-treatment vaccination. Patients preferably should be immunized appropriately prior to starting JAK inhibitors therapy because these agents increase the risk of certain infections including herpes and streptococcal pneumonia. Live or live attenuated vaccines should generally be not to be administered during treatment. Monitoring. Clinical monitoring signs of infections like herpes and TB, new onset GI symptoms that may suggest diverticulitis or GI perforation, and signs and symptoms of thrombosis or cardiovascular disease in patients at high risk of these events should be examined. Laboratory monitoring. Complete blood count with differential is very important. A complete blood count and differential white blood cell count should be obtained after 4 to 8 weeks of therapy, then every 3 months. Treatment should be temporarily interrupted in patients with an absolute neutrophil count less than 1000 cells per mm3 or absolute lymphocyte count less than 500 or hemoglobin less than 8 to 9 gram per deciliter observed during the routine patient monitoring, with dose reduction to maintain adequate levels if treatment is to be continued. Liver function test during therapy is obtained after every 4 to 8 weeks, then every 3 months, and lipids level after 8 to 12 weeks of starting therapy and periodically thereafter should be obtained. Now, the important topic is adverse events of the JAK inhibitors. First is infection. Common is herpes zoster. With Tofacitinib, herpes zoster infection were reported at rate of 3.4 per 100 patients per year. Use of glucocorticoids in conjunction with JAK inhibitors appears to further increase the incidence of herpes. For patients who develop herpes zoster while receiving JAK inhibitors should temporarily withhold the JAK inhibitors. this is very important, until the patient has shown clinical improvement and has completed a course of antiviral therapy. Other adverse events include tuberculosis, opportunistic infections, dyslipidemia, cardiovascular events, venous thromboembolic events, malignancy, hematologic adverse events like anemia, neutropenia, GI adverse events, and reproductive health concerns. So, in conclusion, the scope of the use of JAK inhibitors in dermatology is constantly evolving and expanding. There is growing evidence that JAK inhibitors could prove effective in various dermatological disorders that are otherwise notorious to available treatments. They have an acceptable risk-benefit profile in adult population, and caution needs to be taken in pregnancy, lactation, and children. Thank you.